Hi everyone. I just wanted to first off say I'm really sorry I couldn't make it to the presentation in person. I had to schedule a doctor's appointment for my son, and the only time that was available this week was this afternoon. So I wanted to give you guys this video anyways, and so hopefully this works. If not, we can schedule another time in the future. So I'm David Janiczek. I am a cardiothoracic anesthesiologist in Albuquerque, New Mexico, and I am also founder and CEO of Ginneman MD, which I'll touch on a little bit at the end of this presentation. So today I want to talk about my journey to this point in my career, what that entails, what I've done. I want to talk a little bit about anesthesia. I'll go over a quick case presentation to allow you to think about what we think about as anesthesiologists, and then I'll also touch on the upcoming medical school application cycle. All right, so up to this point, I was born and raised in Bettendorf, Iowa, a small town on the Mississippi River next to Illinois and Iowa. I attended the University of Iowa for both undergraduate and my medical school at the Carver College of Medicine. As an undergraduate, I majored in integrated physiology with a minor in business administration. I participated in several activities as an undergrad to prepare myself for medical school. So I did some biochemistry research for about 2 years. I was an anesthesia technician for 3.5 years. I was a MICU volunteer for 3 years, and I did some tutoring as well. I went on to the residency at the University of Illinois Chicago, where I completed my anesthesia residency, followed by an anesthesia fellowship in cardiothoracic anesthesia at the Ochsner Clinic in New Orleans, Louisiana. Post-training, I started out in California. I was in private practice for about 6 months. Then I moved to the University of California, Irvine, where I was a faculty member for about a year. And then I moved down to Albuquerque, New Mexico in April of 2024, where I resumed being in private practice. And that's where I've been ever since. So you may be asking yourselves, why so many jobs this young in my career? Well, one, anesthesia is a volatile field in the recent couple of years, meaning there's a lot of jobs out there. Whether that's good or bad, that's to be determined. However, I also think it's a little bit of the ultimate search for the right fit. And so I wasn't doing as much cardiac anesthesia in California as I was hoping to do. So I moved down to Albuquerque, where I've been able to do a lot more cardiac cases since moving down here. And that's definitely led to a better professional happiness and satisfaction. So let's talk a little bit about what anesthesia is. I would say it's a diverse field of medicine where we provide patient care in multiple settings, including the operating room, intensive care unit, and non-operating room areas. So that's also called NORA. The area of anesthesia that's probably growing the fastest is the NORA component. So that's really including the GI lab, the cath lab, other areas of the hospital that you may not typically think about having anesthesia personnel present. The training requirements to be an anesthesiologist include 4 years of medical school, so that's where you take all the same classes as and training as your classmates. So you have to rotate through surgery, pediatrics, neurosurgery, all the other specialties before going on to residency, where you focus on anesthesia. So the first year of residency is called the internship year. That's where you're still rotating through medicine floors, ICUs, sometimes general surgery, before going on to the final 3 years of residency, in which you're doing anesthesia every single day. And that's really where you learn how to be an anesthesiologist under the supervision of someone who's been through, an anesthesiologist who's been through training and is certified to teach. There's also a optional 1-year fellowship in a variety of different subspecialties of anesthesia. I chose cardiac, but you could choose pediatrics or OB. You could choose chronic pain, which is a popular choice these days, among others. Those are optional, and I want to stress that there's definitely many people that don't go into fellowship, especially in the recent couple of years. What the fellowship allows you to do is really just hone in on your skills in that one area of anesthesia that you want to practice. Some of these do require the fellowship, so a lot of times hospitals will not let you do cardiac cases unless you've done a cardiac fellowship. In smaller hospitals that may not be able to recruit certain types of these anesthesiologists, you could just go through residency and be just fine. Anesthesia has many practice environments and group dynamics available. So the spectrum includes everything from the traditional operating room setting to ambulatory surgery centers where they're doing smaller cases, but maybe more of them. And the patients go home after the surgery, so they're usually less invasive or easier to recover from, and they don't need to stay in the hospital. You could work in dental clinics or dental offices. You could work in pain clinics, intensive care units, and everything in between. So if you really want a variety of different practice environments, anesthesia is a great field to go into. So when I was in your shoes, I really found these talks interesting to learn how other physicians at the time chose their specialty. And so why did I choose anesthesia? First, I have a love of physiology. And so this was born as an undergrad when I was a physiology major. But basically, anesthesia requires an understanding of anatomy, physiology, pharmacology, and how those fields interact with each other to provide patient care. So we use physiology every single day, whether it's blood pressure management or diabetes management in the operating room, those types of things. We have to use the physiology that we've learned up to this point. Alongside that, we deal with a lot of acute physiologic changes. So anesthesia allows you to see, the immediate impact of your treatment or your drugs that you administer. So, for example, if a patient has low blood pressure in the operating room, I can give a medication through the IV, and I see a response on the monitors almost immediately. It's typically within a minute. There's not many fields of medicine that allow you to do that, and so I never wanted to be a physician that saw a patient in clinic, told them to take a medication and come back and see me in 3 months. It was just too much time to wait. I didn't know if that medication was going to work. I didn't know if they were going to take the medicine, if insurance was going to cover that medicine. And so anesthesia allows me to have that direct impact and see the results relatively quickly. There's a lot of procedural aspects of anesthesia. We do a lot of IVs, central lines, epidurals, nerve blocks, in the cardiac world, transesophageal echocardiograms. So it breaks up your day and makes things interesting. We also get the ability to work with many different specialties of other physicians. So, we can work with different types of surgeons, from morning to afternoon. So we could work with general surgery in the morning, OB surgeons in the afternoon, neurosurgeons after that. So it really just provides a variety of different people you get to interact with. The next one may be positive or negative, depending on how you look at it. But there's really no long-term follow-up for anesthesiologists. We don't typically follow patients long-term in the hospital outside of the perioperative period. And so if you want to have a long-term relationship with a patient or their family, get to know them, see them grow, their family, that sort of thing, it's not necessarily the best field for you. But if you want to have a, kind of a direct impact on a patient at a very vulnerable time, having surgery or a procedure, we can have that direct impact and still make a difference. And then lastly, I enjoy being in the OR. I understand that the OR is not for everyone, and that's just fine. But, I do love being in there, and, that definitely played into my decision. So to dig a little bit deeper, why did I choose cardiac anesthesia? There'll be a lot of overlap with the last slide, but I do want to highlight a few different things. So I love the heart and how that organ functions specifically. And so, I've always been fascinated by the heart and how it operates and also what happens when things go wrong. And so being a cardiac anesthesiologist, I get to deal with heart physiology all the time, every single day. And so that just keeps my brain interested and makes me enjoy work a little bit more. Once again, we see acute physiologic changes, specifically in the cardiac operating room. These patients are very sick. Their vital signs can rapidly change, and we need to be able to assess those quickly and make changes and decisions very quickly to make sure that the patient isn't harmed or anything like that. Once again, lots of procedural aspects in cardiac anesthesia. The ability to work with different fields, although it's a little bit more limited. We work a lot with heart surgeons or cardiac surgeons. We also work with cardiologists, vascular surgeons, thoracic surgeons, and so, we do get a little bit of a variety. I enjoy being in the OR as well. And then one thing I noticed when I was coming through training was, the cardiac anesthesiologists I was working with, they were fearless. Even the sickest patient, the other anesthesiologists might turn down. The cardiac anesthesiologists were comfortable with that, and they had little fear, or at least they didn't show it. And so I felt like the cardiac anesthesia fellowship would allow me to develop those skills to take care of any patient that comes through the door, whether their heart's not doing so well or they're sick in other ways. I can, manage them effectively and get them through the surgery. So what's my typical day look like? I will preface this that this is my specific situation right now. There are many different practice environments and different groups out there, so this isn't typical of all anesthesiologists, but basically at 6:45 I arrive at the hospital. By 7 I've set up my OR. That means drawing up the drugs for the first patient, verifying the airway equipment that I'm going to use is available, and getting other supplies needed for the case. From 7 to 7:15, I see and interview the first patient. So we'll go over kind of some of the questions I ask, but that first patient interaction is usually around 7 to 7:15 with a 7:30 a.m. case start for the first case. Here's where some hospitals start earlier. Some hospitals will start at 6:30 for the operating room. Others will start later at 8. It just kind of depends on your hospital. And then if it's a cardiac case, usually between 12 and 2 p.m. is when the first case ends, and I'm transferring the patient up to the intensive care unit or the ICU. If there's a second case to start, usually between 1 and 3, that's when I'll start the second case. I put 2 asterisks there because sometimes if there's only one case, one cardiac case that day, then you can go home in the 1 to 3 hour time block. If there's other smaller cases that need to be done, sometimes that gets pushed back. However, a lot of times we're heading home by 3 p.m. All right, so let's talk a little bit more generally. What is anesthesia? So anesthesia is made up of 4 pillars. One being analgesia or pain relief. So obviously we don't want patients to feel pain during surgery. And so when we're developing our anesthetic plans, we want to make sure that we cover this pillar and give them a drug that will help them not feel any pain. Amnesia is a loss of memory, so we don't necessarily want them to remember anything about the operating room or anything like that due to the stress and sometimes anxiety-provoking nature of the operating room. So we can give them a medication to help prevent their memory formation for a couple of hours while they're in the operating room, and so they should have no recollection of it. Third is unconsciousness. So obviously we want patients to be asleep during surgery for the most part, which I'll touch on some exceptions here in a minute. But for most surgeries, we want the patient to be unconscious. And fourth is paralysis or muscle relaxation. So this is a temporary thing. We are not actually paralyzing them. We are basically giving them a muscle relaxant that will inhibit the neuromuscular junction. And so therefore their muscles do not work. And so, like I said, this is reversible, and we can give a medication at the end of the surgery to let their muscles, wake up again. So on the bottom of the screen here, you see a spectrum from the awake on the left side to asleep on the right, and in the middle is the sedated state. So this is kind of the spectrum of anesthesia that I think about. So in the awake state, we have what's called local or regional anesthesia. So that means a local anesthetic is where the surgeon can inject a medication similar to what dentists use in the mouth, a lidocaine type medicine that basically blocks pain from a certain area of the body. If the patient's having a small hand surgery, carpal tunnel release, those types of surgeries, they can inject local anesthesia right near that site, and the patient may not need to have much sedation at all. They can stay relatively awake for the procedure. A step up from that is called regional anesthesia. That's where anesthesiologists get involved, and we can actually block, a whole limb, for instance. So for say elbow surgery, we can block a nerve up here in the brachial plexus, so in the neck, and basically make the patient not feel anything from the elbow or from the arm, for that matter, for the surgery. Most of those times we'll give a little bit of medicine through the IV in the operating room just to keep them sedated. But at the same time, we could do some surgeries completely with just regional anesthesia and no sedation at all. In the middle, we have sedation or monitored anesthesia care is a fancy word for it. Basically what this means is we give enough medicine so the patient's not awake, but they're not asleep to the point of general anesthesia. So general anesthesia, I tell patients, is the deep, deep sleep of anesthesia that you typically think about with surgeries. So it satisfies all four of those pillars. Sedation doesn't necessarily follow or doesn't satisfy all of the pillars. Main one being you're not paralyzed during sedation. You may have some amnesia, you may have some unconsciousness, but not to the point where you would need a breathing tube, for instance, or be intubated, which is a pillar or which is a facet of general anesthesia. So these cases, you may have a colonoscopy under sedation. Smaller cases where maybe the surgeon injects a little bit of local anesthesia and we give a little bit of sedation from the anesthesia side, and get the patient through that way. But basically, the point is that it's not to the point of general anesthesia. So that's all the way to the right. And so general anesthesia is that deep, deep sleep of anesthesia that you typically think about. And so once again, that satisfies these four pillars of anesthesia. So another way to think about anesthesia is thinking about it in phases. And so the first phase of anesthesia is called the induction phase. So this is basically where we're getting the patient off to sleep, typically with IV medications. Propofol is used very commonly in anesthesia, and it's something that can induce anesthesia or induce general anesthesia. And so this is akin to an airplane taking off. So it's a very tedious time. A lot of things can go wrong. We have to be very focused at this time and make sure that everyone in the operating room is aware of what's happening. And in case something goes bad, we have to be able to respond very quickly. Once the breathing tube's in, after induction of anesthesia, the patient's fully asleep. Most of the time they're paralyzed at this point. So we'll do what's called maintenance. So maintenance is just like autopilot if you're flying. So basically, the ventilator is breathing for the patient. We're providing a continuous flow of anesthesia in the form of inhaled anesthetic typically. Once again, we're vigilant, but not to the point of, the induction phase where a lot of things can go wrong. And then we have the last phase, which is emergence. So emergence is basically waking up the patient from anesthesia. Once again, with the airplane analogy, you don't just fall out of the sky in an airplane. Patients don't just wake up, immediately. It takes a few minutes after turning off the anesthesia, and it takes a little bit of planning on the anesthesiologist's part to make sure that they're, waking up in a timely fashion after the surgery is over, and not necessarily delaying the next case or anything like that. Once again, emergence, there's a lot of things that can go wrong. So it's a little bit higher time of vigilance, and everyone just has to be prepared for that point. So let's talk about a little bit of an example case here. So we have a 19-year-old male, 75 kilograms, BMI is 24. He came in to the emergency room with sharp abdominal pain that started near the umbilicus or the belly button 2 days ago and is now in the right lower quadrant. He endorses some nausea and vomiting, and he's also febrile, or he has a fever up to 102 degrees. Past medical history, he has some childhood asthma, no longer takes inhalers for that, hasn't had an asthma exacerbation in a while. The surgical history, he doesn't know of any that he remembers. Family history, his mother had diabetes, father had high blood pressure, hypertension, and high cholesterol, which is hyperlipidemia, and then obesity. Social history, he doesn't drink because he's underage. He does smoke some marijuana, and then he has no illicit drug use. The diagnosis that the ER made was appendicitis. As anesthesiologists, we don't typically make diagnoses, and so the diagnosis is often coming from the emergency room or the surgeon, those types of things. So, we're not making a lot of diagnoses. We know what they probably are, but it's usually another specialty of physician that's making those diagnoses before they get to the operating room for us. So the case that this gentleman is scheduled for is a laparoscopic appendectomy. So basically that means that the surgeon will use several small ports and holes that he'll place in the patient's abdomen to then take out the appendix. So once the operating room is all set up and I've reviewed the chart, then I'm going to go talk to the patient and perform a focus history and physical. So I want to ask about any previous anesthesia. And so if the patient's had any anesthesia before, I want to know if there's any complications from it. Did they wake up super nauseous and vomiting everywhere? That can change my management in terms of what drugs I may give them or extra drugs I can provide to help combat that ahead of time. Do they have any family history of anesthetic complications? The main one is something called malignant hypothermia. And so there's a couple of drugs that we use in the world of anesthesia that can cause this. Basically, it causes a sustained contraction of the muscles and it causes the patient to become very hot and febrile, and they can become very rigid as well. And so the we can prepare for it much better if we know about it ahead of time. And so I want to know about it ahead of time if they have anything. So it's not letting me change back. The other things I want to know, any allergies to medicines. Obviously, I don't want to give them any things that they're allergic to. I also um, want to ask about their last PO intake or port oral intake. So when did they last have any food? Did they have any thing to drink recently? This can lead to if the patient had any food recently, or a beer recently, then the stomach can be full, and if the stomach's full when I put that patient to sleep, what can happen is all that content in the stomach can come up through the esophagus and into the lungs and go down the trachea into the lungs and cause a really nasty pneumonia called aspiration pneumonia. So I just want to make sure that they haven't eaten for a while or haven't drank for a while, um, and everything like that. Then I do a brief review of systems. So I go head to toe, make sure there's no major medical issues that weren't included in the chart review. And then if they are, I try to dig deeper a little bit and find out, have they had any strokes or seizures? Have they had a heart attack or abnormal heart rhythm before? Any other lung issues? Just those really major things that might affect my care as an anesthesiologist. So then I moved on to the physical exam. And so a lot of the physical exam is based on the airway. As anesthesiologists, we're very concerned about the airway. We want to make sure that we feel comfortable getting a breathing tube into this patient once they're asleep. So the first way to classify an airway is called the Mallampati classification. So what we have here is basically 4 classes, 1 to 4. 1 is the best, 4 is the worst, 2 and 3 are in the middle. And so as you can see from the picture of the class 1, we have lots of open space here. You can see the uvula, you can see the tonsillar pillars on each side. You can see both the hard and soft palate, everything like that. In contrast, class 4 airway, you don't see anything but really the hard palate. You don't see the tonsillar pillars, you don't see the uvula, the tongue is taking up a lot more of this airway. So class 4 can be associated with a more difficult airway. And so, we may need different means of intubating the patient than just our normal. This would make us a little bit more nervous as anesthesiologists than class 1. Class 2 and class 3 are right in the middle. Class 3, makes us a little bit more concerned. Class 2 is generally fairly easy to get a breathing tube in or gives us less concern. Once again, even a class 1 airway can cause problems, but it's just less likely. The next thing we look at is, alongside the Mallampati classification, is the thyromental distance. So basically the distance from the tip of the chin to the tip of the thyroid cartilage. Longer is better here. So a short thyromental distance can lead to a difficult airway, just because there may not be as much space in the back of the oral pharynx for us to work. The other thing is mouth opening. So we assess this when we're taking a look at the Mallampati classification. And so if a patient has limited mouth opening, for instance, if they have an abscess in their mouth that prohibits them from opening very wide, then it may be harder to get the breathing tube in once we put them to sleep. Other physical exam things we look at, cardiac wise, we look at the heart rate, the heart rhythm. is the patient in a normal sinus rhythm, we call it, or are they in atrial fibrillation? Are they in sinus tachycardia? Those types of things. We also look at the rate. Are they, is their heart rate 150? Is it 75? Just, make note of that so that when you put them to sleep, you kind of know if there's a change from baseline. I like to listen to any murmurs. In a 19-year-old, it's unlikely. However, it's still possible. But if you got a 75-year-old who may not have been to the doctor in a few years, they could be, having a murmur of, for instance, aortic stenosis or narrowing of the aortic valve, and they just haven't been diagnosed with it, and that could change your management drastically. Respiratory wise, I want to listen to lung sounds so that I can compare that to the lung sounds once I put them to sleep and put the breathing tube in. If there's a big change from baseline, then I know that there's something going on that I need to further evaluate. And then lastly, IV access. I want to make sure that the patient has adequate IV access before going to the operating room. The worst thing is to go to the operating room, try to put the patient to sleep with IV medicines, and the IV fails. You got to quickly put a new one in, and it can be kind of stressful that way. So how do we actually intubate? There's a couple tools that we can use. This is not an exhaustive list, but it's several. So the first one is called the direct laryngoscope. So basically down here in the bottom left corner, we have different, we call these blades. They're not sharp in any way, but they're basically pieces of plastic or sometimes metal that are, curved for some of these, and then some of these are straight. Basically what it does is it connects to this laryngoscope here, which is basically a giant battery with a light source. And so the light shines right at the tip here and allows us to see into the patient's oral pharynx. And so you can see this better on the video screen, on the screen up here. And so this is a video laryngoscope. So someone came up probably 20 years ago now, basically put a camera at the tip here, and then it projects to a screen so that we can see better. And so basically what this does is this allows us to see potentially more difficult airways, and allows us to have a higher first pass success rate for intubation. And so this brand is called GlideScope. There's many other brands out there. And then this in the top right corner is basically a mobile version of the video laryngoscope. So there's a little screen here. This is called a McGrath. It's really nice because you can just shove it in your pocket and run to like a Code Blue or something if you have to go handle those for your hospital. But same idea, there's a light source and a camera, and then it projects onto this little screen. On the bottom right corner here, this is called fiber optic intubation. And so what this is this is a fiber optic scope this anesthesiologist is holding. And so basically what they can do is guide this thin spaghetti-like scope down through the patient's mouth into the patient's oral pharynx, and then bring the scope through the vocal cords, and then use it as a stylet to slide the breathing tube off the tip of the scope. So if the patient has a difficult airway, or we assess it as a difficult airway preoperatively, we may jump to just doing a fiber optic intubation from the start. But it also depends on the skill level of the anesthesia provider. And so some may choose video laryngoscopy first, and then if they need to, they can go to fiber optic, but it just kind of depends. These are just two other pictures of intubation. So this provider is doing what's called direct laryngoscopy. So once again, they're using a laryngoscope here in their left hand. They're using that blade, you can kind of see it here, to move the tongue out of the way. Once again, it's not sharp in any way. And then they're putting the breathing tube in behind it. In this cutout view below, you can kind of see where the tongue is getting moved out of the way with the laryngoscope, and the breathing tube is placed in the trachea. You can see the proximity of the trachea to the esophagus. They're right next to each other. And so what can happen is the breathing tube is inadvertently put in the esophagus, which is not where we want it to be. One, there can't be any gas exchange, through the stomach, and two, the stomach will just keep inflating, and that's not good. So during intubation, this is another grading system that we use. It's called Cormack-Lehane grading. So basically, once again, 1 to 4, 1 being the best, 4 being the worst. So grade 1 You can see all of the laryngeal structures here. So the vocal cords are right here, and the epiglottis is nice and out of the way, and you can put your breathing tube in right through the vocal cords. Grade 2 is where you can see the epiglottis here flopping down a little bit, but you can still see a little bit of the vocal cords. Usually the bottom half of the vocal cords are visible. And then grade 3, you really just see the epiglottis. You don't see any of the vocal cords. And then grade 4 is where you don't see any of the epiglottis and you just see the tongue. And so if you have a grade 4 view, you can try to manipulate the patient's head, try a different technique. So maybe go to video laryngoscopy, but really you shouldn't, be blindly putting this in unless it's a true emergency and you just absolutely need to. But I would try to optimize this a little bit more before attempting. Grade 2 and grade 3, in skilled hands, you can slide the breathing tube in often underneath the epiglottis because you know, based on anatomy, that the vocal cords are likely to be right behind there. But it just depends on your comfort level with doing that. You can always just optimize the view a little bit more, or go to video laryngoscopy, or try another technique to try to intubate the patient. All right, so moving on, what do anesthesiologists actually do during surgery? Contrary to popular belief, we don't play Sudoku, we don't do crosswords, we don't check our stocks, at least all the time, only sometimes. But basically, we have a vital screen that looks, this is very simplified, but at the same time, it provides the basics. So we have an EKG or electrocardiogram, so we can monitor the patient's rhythm. So if there's a change in the patient's rhythm during the procedure, we can note it. And so we can also see the patient's heart rate throughout the procedure. This is the patient's blood pressure. And so most cases we'll use the blood pressure cuff that you're typically familiar with that goes on the patient's arm, and measure the blood pressure every 3 minutes or so. In more complicated cases, brain surgery, heart surgery, very sick patients, those types of things, we'll put what's called an arterial line in. So an arterial line is a special IV that goes in the wrist, in the radial artery. And instead of a vein where we can get medications through, an artery, we hook it up. Basically, it's just a small catheter that we place in the artery, and then we hook it up to a pressure sensor, and it gives us a continuous blood pressure reading throughout the entire procedure. Next up is the SpO2 or pulse oximetry. This tells us how much oxygen content is in the patient's blood. And so obviously we want it to be around 100%. And so if this starts dropping, we need to figure out what's going on at that moment. End-tidal CO2 is a way to monitor the patient's respiratory status. So when we place the breathing tube in, the trachea, one of the first signs that we see or what we look for is end-tidal CO2 return on our monitor. And so that indicates that gas exchange is happening in the lungs. And if the patient's end-tidal CO2 suddenly drops during the procedure, there's an algorithm of things that it could be. So we want to investigate. But it's just another sign that we keep a continuous eye on. Another vital sign that we keep a continuous eye on throughout the procedure. And then temperature, we want to monitor the patient's temperature, make sure they're not getting too cold or not too hot either. This screen is representative of the ventilator screen. This is very similar to a Draeger machine, which is one brand of anesthesia machine. So some things are a little bit different on different types of anesthesia machines. Just like car models, we have different anesthesia machines. But basically the same things apply. So we have gas analysis. So what percent of oxygen are we giving the patient? What are our inhaled anesthetic numbers. And so sevoflurane here in yellow is a type of inhaled anesthetic, same with desflurane. And so this ventilator calculates a MAC value, which is called minimal alveolar concentration. So basically what that number tells us is for that patient, how much gas are we giving them? So a MAC value of 1.0 indicates that that's the gas needed for 50% of people to not respond to a surgical stimulus. So if you have a little old lady who's 95 and, she weighs 100 pounds, you may not want to run her at a deep MAC value of 1.6. You may want to keep the MAC value a little bit lower. If you have a 19-year-old who's, 225 pounds, you may want to have a little bit higher MAC value. So it just gives us an indication of, how deep are we running the patient? Should we give them more gas? Should we not? Or are they doing okay? These graphs on the side here are more respiratory mechanics. So, we can measure the tidal volume that we're giving the patient, minute ventilation, once again, end tidal CO2, peak pressures of the airway, those types of things. And then down at the bottom, we can set our settings. So, we can change the amount of oxygen that we're giving them in a percent. And then we can also change the tidal volume. We can change the frequency of the ventilator, all those types of things. So, contrary to popular belief, 100% oxygen is not always good long term. And so, we often run the patients at 50, 60, 70% oxygen, depending on how their lung mechanics are. And so, when we're putting them to sleep or waking them up, we usually put it at 100%, but then we'll often change it, to a lower value during the procedure. All right, so let's fast forward to the end of the case. So now it's time for emergence. In order to do that, we turn off the inhaled anesthetic that's going through the patient's breathing tube. And like I said before, it's like landing a plane. The patient just doesn't wake up instantly. It takes a few minutes. So we try to time that with when the surgery will actually be done. We also reverse the neuromuscular blockade if we gave any. And so basically, we have medications that can reverse that so that the patient will wake back up and be strong. The goal is to extubate the patient immediately after the last stitch or bandage or wound is bandaged. So this is easier to do when you work with the same people every single day. But if you're a trainee or if you're in a new hospital, it can be kind of challenging to time this correctly because you don't necessarily know the surgeons. Do they take a long time to close the skin? Are they quick? Those types of things. So it just takes some time to figure all that out. And then after the patient has their breathing tube removed, that means extubated, then we take them to the post-anesthesia care unit or PACU. All right, so that's the case. Let's just switch gears real quick, and I just want to touch on a few things with the medical school application process. So if you're applying the cycle, so for the 2025-2026 application cycle, just a reminder, the AMCAS application will open May 1st, so that's coming up very shortly. Hopefully you've been working on these components of the application, mainly the personal statement, the work activity sections, so you have those ready to go. There's about 4 weeks where you can work on the application, input all your data, check, verify, double check, triple check, everything is correct. And then you can submit starting May 27th. And so just a word of advice, usually the site, the AMCAS application will crash the first day, right when the submission's open. Don't worry, it'll get back up. It won't delay you. And so if it does crash and you haven't submitted, it's okay. It usually gets put back up a couple hours later, and it won't delay your application that much. I'll go over a little bit more of these in a minute, but basically the personal statement, work activity section, secondary essays, and interview are what I would consider like the main components of the application. The other part would be the letters of recommendation, but that's not something outside of picking which letter writers you have, it's kind of up to those individuals to get the letters written. Overall, the application cycle can take 12 to 14 months from the start of the application, so basically May. This does not include the prep time. So if you started your application 4, 5, 6 months ago, it can be up to 18 months sometimes that you're working on the application. So here's just a timeline of it. So basically in May, you should fill out and submit your application when it becomes available. In June, I would start pre-writing my secondary essays. Most of the time these essays don't change from year to year, so you can readily search these online and generally get those from the last year. They sometimes will change a question here or there, but you can have a good idea of what they're going to ask. If you haven't taken the MCAT already at this point, I would do that. It's not going to necessarily delay your application that much. And so if you wanted to finish your semester out and then take the MCAT in this time, that's a common way to do it. And then the Casper exam is a situational awareness test that you sign up for, and not every school uses it, but more and more are. What it does is basically you record your responses to certain prompts via video, and then you submit them, and you can do it on your own computer. And it's not like the MCAT where you have to go to a testing site to do so. July and August, we complete my secondary essays. You're going to start receiving the actual emails from schools during this time to log in and complete the secondary essays. So hopefully you have most of those written already. And so then you can just kind of copy and paste and get them submitted fairly quickly. I would start doing some mock interviews at this time too, because September through January is interview season. And so you can get interviews anywhere during that time. And so you just want to be prepared. So if that means doing multiple mock interviews, that's what I would do. If you haven't gotten any interviews yet, what I would do is write update letters or letters of intent to schools that you're really interested in. Most schools don't have a limit on that. Obviously, you don't want to be excessive and bother the admission staff, but it's one of those things that will not necessarily guarantee you an interview, but it doesn't necessarily hurt either, as long as you do it in the right way. February through April is waitlist season, so if you're on waitlist, you may have to wait a little bit longer during this time. If you don't happen to get any acceptances during this time, I would start thinking about gap year plans and preparing your reapplication. And so, usually during this time of the year, you can find jobs or research positions or something along those lines to work on the next year while you're still, reapplying. And then July through August is the time when most medical schools start. So what makes a strong application? First, academics. So grades and MCAT scores are very important. I put on here, an overall GPA of greater than 3.8. That's not a requirement. It will just open your doors a little bit more to more schools. Many doctors have GPAs less than that, and they got into medical school. They're, practicing physicians at this point. So if your GPA is not above 3.8, don't worry too much. This is just more to, what makes a strong application. Alongside that, an MCAT score of 512 and above will make you a solid candidate. Once again, if you have an MCAT score below that, that doesn't mean you're not going to get any interviews or not going to get any acceptances. But if you want to, consider what's considered a strong application, this is the score I would say. Activities wise, having a good mix of various activities. So volunteering, shadowing, research, teaching, leadership, all those look good on your application. And having maybe a few of those is beneficial. I would say there is an emphasis on clinical activities. So basically knowing what a physician does, whether that's shadowing physicians or through your volunteer work, those types of things. Oftentimes when students don't get acceptances and they go back and ask the school for feedback, this is a common thing that schools will say is, you just didn't have enough clinical exposure or didn't feel like you had enough clinical exposure on your application. Other application components that can make you a strong application, personal statement that really illustrates why you want to be a physician, not just talking about what you've done or kind of a long form written out resume, right? That's what you want to avoid. You want to really talk, to the admissions committee about, why you want to be a physician. Obviously, you can use the experiences that you've had up to this point and as support, but it shouldn't read like a long form version of your resume. And then other, strong letters of recommendation, are important as well. And then lastly, a strong interview. So I would say that you need to be able to speak about your goals, your ambitions, why you want to be a physician, have it, practiced and know what you're going to say. But the big thing is to be prepared, but not rehearsed. So if you're rehearsed, you're going to come off as robotic. Admissions interviewers will know if you're you're coming off robotic. They're very good at detecting that. So just try to be prepared, know what you're going to say, be confident in what you're going to say, but at the same time, you don't have to practice 1,000 times to the point where you sound like a robot. So how can you best prepare for the application? If you're a freshman or sophomore, I would focus on the academic foundation. So get a good GPA, then start to incorporate the extracurricular activities as you progress. So maybe that's, sophomore year, junior year, and beyond. No matter when you start, keep a log of your activities. this will come in super handy when you're going to fill out your application. So keep a log of what you did, what dates they were, how many hours you spent, any supervisor or person you worked with, those types of things. Any interesting patients or impactful patients that you met during, say a volunteering experience. And so those things can come in handy, not just for the work activity section, but also for the personal statement. If you need, some anecdotal story about a patient you met along the way that really jump-started your desire to be a physician or something like that. For juniors and seniors, I would focus on performing well in the MCAT and finishing out your academic progress, and then just really start getting your application materials ready and prepared. So, getting your personal statement written, getting your work activity section done, all those types of things, and just really make sure you take the time to study for the MCAT as well. All right, lastly, how can I help you? As CEO of Get Admitted MD, I offer full application prep. So basically from personal statement help to mock interviews and everything in between. You can check out my website for more information. It's right here, www.getadmittedmd.com. You can also email me if you have any questions about anesthesia, about cardiac anesthesia, about medical school admissions, any of those types of things. And so here I would have asked for some questions, but unfortunately we are not doing this live. So if you have any questions about any of that, please feel free to reach out to my email. Once again, I'm very sorry I couldn't make it today, but I hope that you got something from this presentation, and if not, hopefully we can set something up in the future to discuss further. All right, thank you guys so much, and take care and good luck with everything.